is Dr. Thorpe. She graduated from the University of Oregon Health Sciences Center in Portland. She actually did two residencies, one initially in surgery at the University of Minnesota, and then she decided that one wasn't enough. Let's go ahead and do a second one, this time in radiology at the University of Minnesota as well. Following that, she was an NIH fellow in cardiovascular and interventional radiology at Stanford. And she's a former chief of vascular and interventional radiology at St. Joseph's Hospital in Creighton in Omaha, Nebraska. And then chief of vascular and interventional radiology at the University of Iowa. Now, currently, she's at Arizona Heart. She's a Fulbright scholar from Brazil. She is also the author of over 50 publications in peer-reviewed journals. And one of the most interesting things that I found was that if you Google or go www.venus.com, she actually has that website. That's pretty interesting. So she's going to talk to us about the diagnosis of a swollen leg, something that we see often. So thank you, Dr. Thorpe.
Good morning. I'm very happy to be here. I've been lucky to be invited numerous times. I think maybe even the first time, right?
Yes.
And I'm so honored, but I'm also really impressed. I think it's the charisma, Dr. Khan's charisma and his great team of people that get you all here. But it's such a privilege to talk to people who really want to learn about this. And I'm giving the Venus talk earlier than usual today, and for many years in my career, I've given the last talk of the day. Because DVT and venous disease has been poorly understood, remains poorly understood, and is not really well taught in curriculum. And many people who have venous disease will go to many doctors before anybody figures it out. Nobody gets it. And I hear this story all the time, all the time. And there are a lot of people trying to fix venous disease who haven't been trained properly in how to do it. So we're creating another kind of problem of complications associated with venous treatment. So I'm going to hopefully teach you some things that I've learned over the years. And as you said, Dr. Mufti said, I did a lot of arterial work before I started only exclusively venous disease, and I've done that for the last 20 years, just concentrating on helping people with veins that can't find anybody else to help them with it. And so I want to share that with you, and I want to leave you with a lot of questions, because we don't have all the answers for sure. And the reason I made my point with Dr. White was that if you start standardizing venous care based on a paucity of data, and very few people treating venous disease for the last 50 years, you're going to come up with some really odd guidelines. Because what I know isn't what most people know, because I've been doing it for so long. And most people don't do it every day and don't do it all these years. So we don't have quite enough data to establish some really useful guidelines that would be good for people. Because, you know, compression has been around for 2,000, 3,000 years. There are statues in Greece that show compression wrapped on varicose veins. So if we just tell everybody who has a swollen leg, you know, that's okay, elevate your leg and just, you know, use compression until you can't walk anymore. I mean, that's really not a very good therapy, is it? And you all know that there's something better out there that we've been developing over the last few years. So these are my disclosures, and I don't get paid very much, Dr. White, just to be part of any trials or talks, but I really like to help teach people about venous disease. And I do acknowledge all the people who help me, my techs, my cath lab people. I can't do all these big patients without people in the ICU helping me and other doctors giving me some good ideas when I go to talks too. And Hannah is here to remind us that, you know what? Venous disease is a people disease. You don't see other animals with swollen legs. It's not something, we don't even have good animal models to study venous disease, if you know that. The only animal we really use effectively is the sheep, because when they put their heads down, they have valves in their neck so all their blood doesn't go down. So It's a very poor animal model for studying stents and venous disease, and so it's a bipedal disease. And there are systemic causes for swollen legs, which we know about. The biggest thing that confounds people is when they see a swollen leg, is it a cardiac issue? Or is it a venous issue? Or are you just not walking enough? Some people may think of renal failure. There are other issues like protein-losing nephropathy, pulmonary hypertension. Drugs is one of the biggest things that causes venous disease or swelling in the legs. But the local causes that we can do something about involve deep vein thrombosis, and I'm going to talk a little bit about iliac compression because that's one of the big hidden issues that we don't see. But the majority of people with chronic venous insufficiency that manifests as varicose veins or some swelling in the legs, even if you don't see the varicosities, is due to reflux. Because if you're walking around all your life and you inherit genetic tendencies for valves to disintegrate, or there's pressure from your iliac vein, which you didn't know about all these years, you may develop varicosities. And that's a valve problem, not an obstruction problem. And then there's a lymph system that most people have no idea what it is. If I ask people, you know, like Jay Leno used to go out with a microphone and ask people what things are, and they're so ignorant. It's appalling. But most people, I mean, most of us do not know what our lymphs look like, where they are, what they do. We'll talk a little bit about that. Cellulitis gets confused with lymphangitis a lot. Lipidemia is another issue that mostly is with women. I'll show a picture where we store fat in our legs. And then there's RSD, and then there's this catch of things where we don't really know what's going on, or maybe multiple things. And by the time you get in your 60s and 70s, almost half of the people have a combination of venous disease as well as arterial disease. And that's why it's so important for all of the people who are seeing people with vascular disease to think of it in those terms. It's not just arterial and ignore the veins. Okay? They're all connected. Now, once in a while, and this is sort of like once in 30 years for me, a person will come in with a swollen leg, and it's not vascular. And you just don't think of that because if you're a vascular specialist, it's like you can't go to a Cadillac guy and buy a Lincoln, you know. They're just thinking about what they want to sell. And so this is an ultrasound from a patient who has a huge, looks like a cystic area. Could it be a hematoma? Could it be something else? And here's a picture of the CT. And actually, it's a huge tumor making this leg swollen. And there is very limited venous disease. There's compression of some veins, but he hadn't thrombosed. So once in a while, we do get fooled that the swollen leg has nothing to do with vascular. Vascular components are these, for the most part. And the venous pathology has to do with the fact that the tube can get blocked. It's like a roadway, and you can get blockage, which causes a road jam. I always use the metaphor of traffic jams to people. Or you can have valves that don't work. There are 7 valves between your groin and your knee, about. There are 100 valves below your knee. I want you to think about why you would have 100 valves below your knee, and what happens when you have clot in those tubes, and how it damages valves, and what's going to happen if your valves below your knee don't work. I want you to think about that. So what can go wrong in veins is that you can get obstruction, and this is a picture of clot in formation, which is very rare. I mean, if you went there a day later, it would be all filled, the whole vein would be filled, and you wouldn't be seeing this outline of a clot. So it's a dynamic process. It starts with a little bit, and it grows at a rate that is dependent upon the rate of flow, possibly your blood type, any damage to your veins. There's a lot of variables that we don't know about in terms of how much clot starts and how fast it grows and how fast it dissolves by itself. Some people do it well, some people don't do it very well at all. If you don't do it very well at all, what happens? Your leg stays full of clot, and it's not good for you, and the traffic jam is inevitable, and you have post-thrombotic syndrome, or you have a bad leg. The trouble with almost all over the world, we cover that up. We wear pants. So if you have any leg swelling or scars on your legs or even on your arms, you don't like show people. It's all covered up and you go on as if you're normal because you don't want to whine. You don't want to complain about things you don't think there's anything to do, that we can do anything about. But now, since we're beginning to do more about diabetic legs or venous swelling, it's important for people to have doctors who can connect the dots. So this fleeble lymphedema may be a new concept for you because what happens is when you get a lot of blockage in the venous system, it creates pressure. And then it exerts pressure on the lymphatics. And that's when things start to change as well because the lymph system is very important. The lymph system, the way I think about it, is a lot of cellophane noodles, just paralleling the arteries and the veins. So when those aren't working properly, you start to get fluid in the soft tissue because the proteins leach into the soft tissue or third space. It's not fluid. It's not fluid. We'll talk about that a little bit. So chronic lymphedema can be either unilateral, it can be both, or it can be just bilateral. I mean, it can be one or the other, or it can shift. Do you know that a lot of people that I treat with inferior vena cava syndrome, which is a central vein, only have unilateral swelling? It fools me too, but they develop some compensation on one side and not on the other side. So you can't predict when you see one leg swollen if there is more than meets the eye, particularly in the central venous area. So it's important to investigate it. Now, here is a picture of an unfortunate person who has lymphedema on the right side. Perhaps they were born without proper lymphatics or lymph nodes. They could have, see what happens is they have ended up storing an awful lot of proteins in the soft tissue, which then lead to an awful lot of swelling and tissue imbalance, tissue fluids imbalance. So she has a stocking on at this point. But this is to show you that with like any other disease, you have to have a pretty comprehensive history of medications, trauma. Most of the time when you see something like this, and we don't see a lot of this in our country. When I lived in Brazil, I did see a lot of elephantiasis. So, and you have an infection, you can get blockage. Most of the lymphedema that I see is due to infection, untreated infection, or infection in the leg that damages the lymphatics. And then subsequent to that, they will have swelling in their leg that's not venous. Also, hysterectomies and other surgeries in the pelvis will interrupt lymphatics, and later in life, people will start to have swelling. Somehow, for some reason, there's kind of a delayed presentation. You can see the list of bilateral edema secondary to drugs is pretty extensive. Norvasc, we know, is one. So I always ask my patients if they've taken testosterone, because there's a huge increase in DVT in men, since they're adding hormones as a risk factor. This is interesting. It's a study that's a little bit older, but 45 patients with bilateral edema were evaluated by the internist, and he tried to figure out if it was cardiac, venous, or lymphatic in nature. So he did all those studies to then get the data which would evaluate this condition, right? And this is what he underestimated the amount of cardiac disease involving, and you see the trouble is it could be one or more at the same time, so it's not that easy. But venous disease was overestimated. Nephrotic syndrome is definitely a possibility for almost a quarter in the study. And lymphedema wasn't that common in this particular study, but I think lymphedema is much more common now. And that's a good question. Why is lymphedema so much more common now than it was 40 years ago? Or we weren't seeing it then, so it wasn't on the register. So that's a question. So what about if you're male or female? It seems to be more common in females. It's usually unilateral. What about this pedal sparing? I think it's the best trick I can leave you with today. Does everybody know what the stemmer sign is? Stemmer sign? Stemmer sign is if you pick up your skin right below your finger, right here, and this or right below your toe, and you can pick it up, and it'll stay up a little bit. But if you have lymphedema, you can't do that. And that's called a positive stemmer sign. So people who have lymphedema in their legs, one or both, their swelling does not go down overnight. When you ask people, does your leg look better in the morning than it did when you went to bed? And if it's venous disease or coronary disease, they'll say yes. But if it's lymphatic, it doesn't do anything usually overnight, because lymphatics require muscle activity in order to push the fluid through the lymphatics. And if you're laying down and you're horizontal, then the lymphatic channels, if they're blocked or affected in an adverse way, they don't make very much progress overnight. So if your foot is puffy, your toes are puffy, the dorsum of your foot is a little bit of a round, and one or both of your legs kind of look straight, you'll see some pictures here, that's lymphedema. The trouble is it can be lymphedema associated with venous occlusion. So we'll get into how you investigate that. So these diagnostic tests, as you know, are designed to rule out certain types of disease. And lymphoscintigraphy is not that easy to order anymore. There aren't that many people who know how to do it. You have to put a little bit of a radioactive dye into the lymphatics at the foot. And it's a tricky study. I did it a long time ago. But most they do it at cancer centers now. But it can show the uptake of the radioactivity in the lymphatics. And it's an important study if you think the lymphatics are not working properly. Ultrasound we all know about. Cardiac echo certainly would support if you have an ejection fraction that is bad. And then you can combine that with the lab studies that show how much albumin there is, etc. So there's a way to evaluate all of this. And venous ultrasound is our go-to study for venous disease. The trouble with venous ultrasound is, and think about your own place, if somebody comes into the emergency room and says, swollen left leg, rule out DVT. Where do they do the ultrasound? They do the ultrasound from the groin to the calf. And then they do it pretty quickly, a little bit of compression here and there, everything's compressing, and they say, no DVT. And then if you say to the tech, well, tell me what the waveform looked like in the common femoral. Or did you look in the external iliac just a little bit? Was there a flat line or a phasic waveform? I said, oh no, I didn't look there. I just saw that there was flow. Well, there can be a lot of flow into some collaterals above the common femoral, and you'll get a normal ultrasound from the groin down. But they may have a completely occluded iliac vein that is the cause of their swelling. And what happens? They're sent home and told there's nothing wrong, you don't have any DVT. It's a misdiagnosis. Missed and misdiagnosis. So that we just went through this a little bit. So all these studies can be done to rule out people for having these problems. What I want to emphasize is that when you have a left leg swelling, it's not a good idea to give them Lasix. Why? Sometimes there's a little bit of change in their whole body because they do diuresis, but Lasix without potassium leaches people, their electrolytes, and also it doesn't do any good for the swelling that's caused by venous insufficiency or lymphedema. It doesn't do that because it's an intravascular remedy, and what we're dealing with venous insufficiency and swelling in the leg is third-spaced fluid that doesn't really pull out easily. If you use albumin and Bumax, and we were talking about that last night, that's an effective way of pulling fluid into the intravascular system. But Lasix usually dehydrates people. And what's a risk factor for DVT? Dehydration. So it's just not a good therapy. You have to think that one through. But it's I don't recommend it at all. Now here's a 63-year-old man, heavy smoker, no insurance, swelling and tightness in his right leg. He's been this way for a couple of weeks because he doesn't have any insurance. Didn't want to go to the doctor. He was thinking, well, maybe it'll get better. And the sneaky thing about venous disease, it gets better overnight. The leg is really swollen by the end of the day, and it's tight and uncomfortable, and in the morning it's just not quite so bad. So every day you make that decision. Should I go talk to somebody today? Should I make an appointment? No, it was a little better than it was yesterday. That's the sneaky thing about it. So he was on Lasix for months and pain medication. So they become addicted to opioids. A lot of these people come to my office with chronic venous disease of the obstructive type, and they're addicted to Percocets or Vicodin. So it's really it's another problem to them. And on top of that, they're constipated. And that's a bad thing for their bodies too. So not only are they immobilized, they can't exercise, they're unhappy people, and what they have is an obstruction in their venous system that was never addressed. There's another person who actually has lymphedema. See how his foot is more swollen? His foot is more swollen. If we go back here, the foot is slightly swollen but not puffy. The other one looks better. This one is you can have a more exaggerated sign of it. This shows the hyperpigmentation on the left side associated with chronic high venous pressure. Why is that hyperpigmentation there? It's because of the slow flow of the blood near the surface. The blood corpuscles do in fact break down and they deposit the iron. And the hemosiderin causes this freckle look at first, and then it gets darker and darker and darker. Interesting enough, when you open up the veins and they flow better, some of that darkness dissipates, and I think it's because the blood is flowing better and you don't get the purple hue coming through. But all these things are poorly described. Here's another person with venous hyperpigmentation on the left side. I have a great collection of pedicures too, by the way. I'm going to make a coffee table book. Put it out there. You see here at the ankle on the left side, there's medial malleolar hyperpigmentation, which is where our ulcers usually form with venous disease, whereas diabetic ulcers form in the toes and the ankle, the heel, the toes. Venous disease usually forms on the medial aspect, and it can form on the lateral aspect as well, because that's where the skin starts to break down because the oxygenation is insufficient. There are many theories out there, but that generally it's just a necrosis of skin that's very slow over time. And here is a person, so many of my patients now have tattoos, I can start to keep them straight without their names. But again, you see that the skin changes. The classification of CEAP for chronic venous disease would be 4 for skin changes. And here's a patient with a very large left leg, but he also has varicosities. So some people manifest with both varicose veins, which are superficial veins that you can see through the skin because of high pressure and tortuosity, and a left leg edema, which is related to his iliac compression. Now, what about this lady? What do you think's there? You see somebody like that in your office? Well, you can see the straightness of her legs. She also has hyperpigmentation or changes in her skin, which can be associated with long-term high pressure in the system. And there's a little bit of different manifestation with lymphedema than just pure venous. But in her case, she has saphenous insufficiency to some degree, and she has lymphedema. Why does she have lymphedema? There are probably multiple reasons. You can look at her pelvic history, whether or not she's had a hysterectomy. Maybe she's not moving. Maybe she doesn't. You know, the lymphatics are sluggish and not working properly. And you see how her feet are a little bit puffy and her toes are a little bit puffy. If you put compression on these patients with Circade leggings, they can't put stockings on hardly at all. But Circade leggings are non-elastic Velcro contraptions that go around. You can push that fluid out over the course of the day and the legs will get much thinner. And it's not uncomfortable. So you can have people, but they're kind of an orthotic look. So people have to really be motivated to put them on, but they do work well. And the people who like them and put them on really swear by them. So here's another person I want to show you that when you think someone may or may not have left leg swelling or iliac compression and you're looking for it in your clinic, have the patient, when they're on the table, bring their knees up and then just look at their ankles without their whole leg. The whole leg kind of deceives you, but when you bring your knees up and just look at the ankles like this, you can see very quickly that the left leg is edematous compared to the right. And then you say to that person, has your left leg always been tight? Now, sometimes they'll say no. Well, they'd say, was your left shoe tight? Have you ever bought a bigger size shoe on the left or not? Oftentimes you'll have people say, yes, my left shoe has been tight since I was a kid. And that's a sign that they have iliac compression. And it's important for us to identify these people because people could have had undetected DVT during a pregnancy or during an accident, and they could not have clotted at all yet, but they're at risk for clot. So we could be much more proactive now in preventing DVT or treating the sequelae of DVT if we recognize this left leg edema, which I'm sure you see frequently when you're looking for other things. Okay, I just want to mention briefly that you can get collateral veins as a sign that there's something blocked. In this case, it was a superior vena cava, and this man also superior vena cava. And the hands, just as much as the feet or legs, can get edematous because of central blockage. And you get manifestations like this on the abdomen, which means in this case, it could be an IVC, but in her case it's a SVC. It's a central vein that's occluded. Or in this man, it's an inferior vena cava that's occluded. People don't show you these things. Just like, you really have to carefully ask men if they have a lot of veins in their scrotal area, which is a sign of varicocele, which is related to iliac compression and overload of the gonadal vein on the left side usually. And women will have vulvar varices that they don't want to talk about. But you can ask them very politely, do you have any veins in your pelvic area that are sore or hurt when you sit down? And with men, it's almost 15%, they say, but in the literature, that have varicocele, but it's really not talked about because most people don't know there's anything you do about it, and they only come to light when they're looking for fertility treatments. So again, a right leg swelling, and sometimes there's a compression of the right leg just like there is on the left. And here's a lady who actually just had, she was riding her horse, and the horse bucked, and she came down really hard on the saddle horn. And that was trauma enough to cause a big hematoma and then a right leg edema. Now, the reason why I put this slide in here is this. I remember her well because it was my birthday, and it was her birthday. And you know what the internist said? The hospital said to me, hey, there's a lady up in room such and such. We're going to send her home today, but she has a DVT. She has a big DVT. But we're going to send her back to her home on some Xarelto. Why don't you stop by and see what she's like or what's going on? So she had not had a complete pelvic exam yet in terms of ultrasound. And when I take one look at her leg, I said, you're going to go home with that leg? Well, we can take care of the clot. If it just has been there for like 10 days or so, it'll come right out and your leg will be back to normal. And so she agreed that that was a good option. I gave her all the risk factors. And so she did get a very good result. And I did not put her on Xarelto after the manipulation and the angioplasty. And she did not get a stent, actually. It was just a hematoma narrowing the vein, so I knew that would resolve. So we followed her carefully with ultrasound. But we did put her on Coumadin for 6 months, and then Plavix. And now she's on aspirin. And she's done very well. So you see, nobody connected the dots with this woman. Or the standard of care is what I don't agree with. I think someone with that much clot who has a risk for a pulmonary embolus needs to be treated effectively. So here's another person. As you see, the left ankle is swollen. And here's a patient in whom the IVC was occluded. And he has stents as IVC and iliacs. And I say to him, do you want me to treat those varicose veins too? Aren't they bothering you? He said, no, they don't hurt. I've had them all my life. I said, well, Phil, when did they start coming out? He said, well, I think, I started seeing them when I was 17 or 18. I said, ha-ha. I want you to know in here that if you see varicose veins in a teenager, that is a red flag for a central venous occlusion. You have to look for it. It's not normal to have varicose veins in a teenager. It's very unusual. So if, in fact, that's the manifestation, and it's sort of painless, but they don't like it, and they cover it up a lot. You have to go looking for DVT elsewhere, because it's not just an ablation issue and do a saphenous dripping intervention. So this is his ultrasound from Sydney. He, was it in Sydney? He's from Australia. And he actually, this was almost 10 years ago, but he found us on the internet through Venus.com, which is very effective. But now more and more people are doing things everywhere. But in fact, he had an obstruction, and he had it for a long time. And so we were able to very successfully treat his IVC iliac. And then I actually sent this particular patient to Nick Morrison for the laser ablation. So he got everything treated while he was here. So I think what we do is we sometimes look for things, or when we look at things, we don't see it. You only see what you know. And if you're not looking for it, you can actually look at something that's abnormal, and it's just a blind spot in your brain and your knowledge. Sometimes it's very damaging to people when you don't recognize things, but we usually look for things that we can do something about. And that's where I want to mention this. What do we do with people with vascular disease? With arterial disease and venous disease, we usually tell them to walk. Walking is good, you know, it makes your lymphatics move, it moves your muscles. But if you have venous obstruction, what happens? More flow comes in through your arteries, and you can't turn off the spigot. You can't like downgrade the arterial inflow because the venous outflow is partially blocked. It won't work that way. The more you walk, the more blood comes in, and the more it will hurt. So there's such a thing as venous claudication. It hurts when you walk, and when you sit down, it gets better. But you also have swelling and heaviness and tightness. And it can vary, but it's called venous claudication. And there's a myth. I mean, you don't develop more collaterals just because you start walking. As soon as you're obstructed, your body will use whatever collaterals it can. They don't grow if you start walking more. It just hurts more. Some people have better. It's like noses and fingernails. Some people have bigger veins and some people have smaller veins. And if you're lucky, you have bigger veins. If you have big carotids, I think you can live to be 100. But if you have small carotids and they fill up with plaque, then you probably have troubles in your 80s and 90s or sooner. Compression. What can we do? Compression's been around for 2,000 years. And we use stockings and pumps. That's usually the manifestation. So that works. But for the most people, they complain a lot, they're hot. And I do want to mention that the white compression stockings they give you in the hospital are only 10 to 18 millimeters of mercury. They're really not meant for ambulation. They're just there. TED hose are just for lying down. They're pretty cosmetic. So if your patients are wearing stockings, you say, what color are they? If they say white, you can say, you can throw those away. They're not doing you any good. They're just fooling you. And the good ones have to be replaced every 3 to 4 months to keep their therapeutic compression. Now, what else? You can remove the varicose veins. You can't remove deep veins. Removing deep veins causes all kinds of problems. Causes obstruction, and there aren't good collaterals. So we stopped doing surgery on veins to remove them a long time ago. The palmar bypass was one form of removing the veins that didn't work very well. That was to bypass from left to right with a borrowed vein from your saphenous system. Speaking of bypass, there are very few venous bypasses that have ever stayed open for very long. Once in a while, I found a palmar bypass that had been open 20 years. But it wasn't doing any good because his IVC iliacs were all occluded. So he was shunting blood back and forth, but both of his legs were so blocked that he was very symptomatic. And once you put the stents in, you need flow to go straight up from your legs to your heart. So you can't have a bypass that's going to steal flow. So I actually closed it down, and he got even better from not having a bypass that wasn't working. So bypass doesn't work in venous disease like it does in arterial disease. Thrombolytics and stents now are available to people, given the risk-benefit ratio that you can analyze. And if those work, fine. If they don't, You tell people in every category, elevate your leg to take the pressure off, because if it's against gravity, it should help, because the problem is a lot of pressure when you're standing up. So if you're not standing up, but you can't have people spend the rest of their life in a recliner. They just can't do that. So they come to you for help, and you need to open up the veins. And if that fails, people have the option of amputation, and there are very few people who need an amputation from venous disease. The only case I can think of are when the ulcer, which is gone unattended and untreated, goes into the posterior tibial vein near the ankle, or the lateral malleolar area too. The nerve pain can just make people just say, take my leg off. It's very sad. But I've only seen a few people like that in my career, because we're in the business of trying to help people not be that way. But that's, in fact, usually the story when you see somebody who said, I lost my leg because of venous disease. And they're usually people who have hypercoagulability, they get a lot of DVT in a young age. And then they just have a terrible leg, and they're going into their 20s and nobody knows what to do about it, and by then they get these really bad ulcers. So we have been able to treat a lot of people with ulcers and have the ulcers heal, and the reason was they had obstruction up higher, many of whom on the left side have an iliac compression. So the huge case of swelling is this iliac compression syndrome. Okay, good. So I've spoken before about the iliac compression syndrome, but I really want to share with you again and show you the pictures so that you recognize it. This is an iliac compression. Remember, this patient is prone. So it's really the left side that you're looking at, because they're lying on their abdomen. But you can see where the artery will make a big indentation in the vessel as it goes across. And we can look at that with intravascular iris now, intravascular ultrasound, and we can do a lot of great measurements, and I have a method to always choose the right size stent for the person and put it in and open up that vessel, and it stays open. We have people who now have been stented for 23 years, and they're doing fine. Again, there are multiple variables to keep those stents open, but for the most part, the success of your venous stenting has to do with the person who does it and the judgment they use to manage the care afterwards and the monitoring they do. The monitoring is very important. So May-Thurner syndrome is this extrinsic venous compression. Well, guess what? Everybody's made this way. So a third of the people in this room have a compression that's more than the other two-thirds. So you can divide everybody, and they did this with autopsy results, that at least a third of the population, because of the curvature of their spine and the juxtaposition of the artery on top of the vein pounding all your life since you were born, it can thicken that vein and make it so that it's just a slit or multiple slits, so that when the flow comes up to go through the left side up towards the heart, it runs into this roadblock of sorts. It'll go through the pelvis or up along the side or completely occlude. And when does it occlude? It occludes when you're doing something really normal and fun, like driving from here to Denver. You know, or sitting on a plane to Hawaii. That's the problem with iliac compression, that you have to be aware of the fact that you are at risk for DVT if you have an untreated May-Thurner compression. You can see how on the bottom one, you can see how it can make multiple channels, or in the middle 2 channels, or just a narrowing. So there are various patterns from the way this artery will sit right on top of the vein. Right here, see the, oh, you lose it? Oh, I see, okay, great. There, wow, it's big. The artery sitting right on that vein. That's why CT can show us a lot of times that this is the problem. And it's been known for 61 years, really. It's nothing new. And it's such a high prevalence that when evaluating a lot of people, doctors Raju and Neglin down in Mississippi have reported a lot about non-thrombotic iliac vein from issues. And there was a big debate about 20 years ago about whether or not we should stent these people. And we did, in fact, of deference to Dr. Paul Maz, who's with us today, find out that the Paul Maz stent wasn't the best stent to use in that area, because right under that artery, it can be subject to compression. So this is where we use self-expanding stents and have found that they're more successful. Now this is another place where you can see the multiple changes of the vein, where you can see all of these channels that have come in a patient, multiple channels. And so that's why venous disease can be a lot of fun for people when they do the exams, because everyone's a little bit different. And this is a CT 3D reconstruction that shows you how tortuous the arteries can become and compress, not only on the left side, which is right here where you see the artery going across the vein, but right here on the right side you can also get a compression. So that's why some right leg DVT is due to iliac compression way up in the pelvis. So here's a lady in Iowa City that we treated. Here's a man from Liverpool. Here's a 33-year-old woman from New York who had non-thrombotic iliac compression. I'm showing you all these pictures so you can see, get it in your mind what it looks like. 27-year-old woman from Reading who had an iliac compression, which when they measured it on venography, they said, oh wow, that looks way too big to stent. But they didn't know at the time that intravascular ultrasound is a way to measure these, because the compression is front to back. So if it's 2 millimeters from front to back and 22 millimeters from the side to side, actually what you want to do is correct the 2 millimeter part with a stent that's going to stay there. And I have a formula for figuring that out now. So we don't want any stents to move, and we want them all to fit the artery or the vein properly, so they get a good repair that'll last a lifetime. Some of the people who come to you will kind of defy looking at their leg because they're all wrapped up, and it doesn't smell very good if it has Pseudomonas, and you'll say, something wrong with your right leg, huh? Oh, yeah. And this was a patient, and interestingly enough, I want to just throw this out here. I've taken care of probably a dozen people now who are mentally challenged, that they don't speak very well. Their parents come with them or caregivers come with them. And these people get substandard care because they're put into institutions and they're left there immobilized. And this patient in particular had ulcers that weren't healing for a number of years. And finally his parents heard about me and they brought him down to Arizona Heart. And we were able to stent both sides because both sides were affected with iliac compression. And that was what his ulcer looked like when we unwrapped it. So he healed up completely. And his parents have now been able to take him to their home because he can be with them because he has so much less maintenance, so to speak, or care during the day. But there are a lot of people that are in these institutional living situations that have a lot of venous disease that's not being addressed. So if a third of the people in this room have iliac compression, then you're at risk for DVT or may have had it. That's 100 million people in our country. We think that there are probably 15,000 vascular specialists, not all of whom do venous work, right? But if they were, if we trained them all, that would be 6,600 people per doctor to fix. If you were trying to fix 6,000 people and you work every day of the year, it would take you 18 years to treat those people. This is a big number, isn't it? It's a big problem. And it's not obvious because people wear pants and they don't talk about it, and when they go to their doctor, they don't, if they even complain, I'd say, I don't know, you can correct me, but 8 or 9 out of 10 doctors, if they hear that my left leg is swollen, they don't know what that means. They're not thinking about venous disease. Which is why Dr. Khan wanted me to come and speak to you, because we want everybody to know that it's in your family. It has nothing to do with what culture you're from, what country you are, what nationality you are. It's a human condition. The incidence is very prevalent, which we've confirmed, and you can figure it out on CT or ultrasound. The trouble is CT is expensive, and ultrasound is tech driven. You know, it depends on how good the tech is and how willing they are to spend the time to do the study. And not all of them are, and not all of them can do a good job. So why I'm showing you a lot of pictures is so you can recognize the physical findings and the history that goes along with this kind of problem before it gets too late. And a person who has an iliac compression, if they add other risk factors to like testosterone or hormones, or cast or brace after they twist their ankles, something innocuous, or long car trips, or work by driving a truck, or sit at a computer all day, they're adding risk factors to May-Thurner iliac compression. Now, there's this myth that May-Thurner syndrome is more prevalent in women. Well, the syndrome may be more prevalent in women because women have pregnancies and they take more hormone therapy. And those are risk factors for blood clotting on the left side if you have that iliac compression. So the iliac compression is equal in men and women. I can tell you that for sure. But the syndrome has now started to go up in percentage with men because they're taking testosterone. And these kinds of drugs do make you at risk for DVT. All those injections, so steroids too, they kind of make a risk for. Genetic mutations we test for all the time. About 10% of the population has a factor V Leiden. So you may or may not have. If you have a family history of DVT, that's important. Pay attention to that. But the rare ones like protein S deficiency, they go in generations. It's an autosomal dominant. So if your father or mother has it, you have 50% chance of inheriting it as a defect in your bloodstream. So usually protein S families are well known as multiple generations of PE and DVT and ulcers in their legs. Whereas factor V Leiden could be a point mutation. It may or may not be inherited from your parent, and you might not see it manifest as pulmonary embolus or DVT. But in the past, a lot of people thought that DVT was just bad luck because you're sitting around too much. And it has nothing to do with that. It has a lot to do with these multiple variables that are like a perfect storm. You can have some of these variables, but if they're not lined up on a given day like this, you're not going to get DVT. So it's hard to predict who's going to get DVT, but I can tell you if you have left leg swelling, you're taking hormones, you're going to sit in a car from here to Los Angeles, or take a long plane trip, maybe you ought to think about the fact that you have to drink a lot of water and get up and move a lot to mitigate those risk factors. And it's not something that's advertised on TV. It's something that we're trying to teach people. But it's something that every human being has risk for. So, let's see, where are we? The good news, this is why I show this picture, is that you can do something about it. These stents do work. We do know how to open up these veins that are chronically occluded, and your legs can get back to normal or near normal. So we're talking now about quality of life. We're not talking about losing your life unless it's a pulmonary embolus. But if you have acute DVT and you have it on the left side, what's your chance of getting a pulmonary embolus? It's hard to say, isn't it? But don't you think that acute DVT on the right side, where you don't have a compression, may be a higher incidence? But unfortunately, PEs don't get labeled right, left. And when you look at the lungs and the CT, you can't tell where it came from. I mean, with all the technology we have to go into space and everything, we still can't tell if a PE came from a left side or right side. And once it leaves the leg, you can't tell that it has been there, unless there's residual trauma still sitting there. And you say, whoops, you have DVT in your right femoral. That's maybe where your DVT came, or your pulmonary embolus came from. So a lot of people die within the first hour of having a pulmonary embolus. It's not trivial. So, but this person had DVT for several months. He came from New York City, and look at his legs. It became really good after we treated him. And this is an example of how you can show on CT that this whole part of the vein is missing. It's supposed to come up here and go up to the IVC right here. And this is the body's natural formation of a bypass vein, which is not too effective in relieving the pressure in this left leg. And the palmar bypass is when you borrow this vein, the saphenous vein, and you take it out and you switch it over and you hook it up to this side. So you do a bypass across the pelvis. But the longevity of those is very low at 5 years. Very, very poor patency rate. And there is the one. So I wanted to go here just a little bit to lymphedema, because I think it's important for you to see lymphedema. We have to go down here. I enjoy giving this talk so much, I have to go faster. Sorry. Any of you are interested in venous disease? We have a 3-day forum in Chicago in July. All venous, one room, and all arterial, the other room, and you can go back and forth if you want. It's a very good CVC in July in Chicago. So here we are. I want to share with you this lymphedema information because lymphedema is sort of rampant now. It's like a disease we're starting to recognize. And the primary function of your lymphatics is to retrieve these plasma proteins that come into the soft. They're delivering nutrients to your tissue, so we have to have the veins bring through the oxygen, and the arteries bring the oxygen, and the veins take it back to the heart, and the whole system keeps circling. But when you have these delivery guys of the plasma proteins bringing the nutrition, the delivery guys have to go back into circulation and go back and get some more nutrition or nutrients for the tissues. And what happens is when the lymphatics are blocked by either a big mass, like lymphoma, or trauma, hematoma, or some irritation within the system, the pressure from the venous system being occluded, then these proteins accumulate in the soft tissue. They can't get back into circulation. Well, that's really bad because they denature. And the dying proteins are consumed by macrophages, and when those come and they try to clean up the debris, then it excites the fibroblasts, and then the collagen is produced. And then what happens, there's excessive collagen and denatured proteins all sitting there in your soft tissue, and you get chronic inflammation or an inflammatory condition in your lower legs, which is complicated by the pressure always being there. And the skin starts to thicken, and it becomes dense and fibrous. And a lot of us have this in our lower calves. There's not so much edema, but there are skin changes of darkness and discoloration as we age, and it's mostly related to poor lymphatics. And this is a Stemmer sign where you can pick up the skin. If that's positive and you can do that, then you don't have lymphedema. You must have venous compression. So here's a lady, and look across the top, the thigh. In the thigh, she has left side 50, 47. We did stent her because she had an iliac compression. Then she went back up to 49, then went back up to 50. And this is over a period of 2 months. So what's going on here? Did her stent fail? No, it was perfectly open. So we had to start looking for lymphedema. And in the calf, you can see a lot of fluid trapped up here in the soft tissue. It's not looking normal. And when you look on her CT, you can see this pattern of sort of honeycomb. So that's chronic edema here, and her leg is much bigger than the other leg. So she has lymphedema combined with a previous problem of hysterectomy and venous disease. But stage 1 is this spontaneously reversible fluid collection, which sometimes your legs will look a lot better if you wrap them. Oh, you'll find that, my legs were swollen last week, but they're not now. It has to do with a lot of salt intake and how much you're walking, how much hydration, and the counterintuitive to not drink. They think, oh, I've got all this fluid stored, I shouldn't drink. But lymphedema responds really well to hydration. So the more water you drink and the more you walk, the better your legs look. So, unless there's obstruction. So there's stage 1, there's stage 2, which is not, it's still it's spontaneously irreversible. I mean, it starts to get more of the thickened skin and the hard skin and more swelling that stays there all the time. and there's a man who just really has lymphedema. But you know what? It turns out that he was a paratrooper in Panama, and he walked through the swamps a lot. So he got a lot of lymphangitis. So he ruined his lymphatics, but his skin is really taut. It's become very hard and darkened because of the lymph changes that I just described with the proteins. You know, he has a lot of pain. A lot of people who have big legs that swell don't have any pain at all, but he feels pain. Okay, thank you. So lymphostatic elephantitis is this kind like this, where they have stage 3 lymphedema, and it even gets worse when you go to tropical countries where they have filariasis. So primary lymphedema can affect all your arms and your legs, and it can be present at birth, which is very unusual, but we have seen about 3 or 4 patients now in my career that have a left iliac compression, you stent it, and the swelling does not go down. And it turns out that they were born with an insufficient number of lymphatics and lymph nodes on the left side. So you have to consider this as a possibility, particularly in young people or people who have had nephrectomies or hysterectomies, that their lymphatics are not going to be sufficient to reduce all the swelling. This is a story of a young man who was born that way, and you can see his left leg is in fact quite swollen still, but he does have a stent that works perfectly well, and it made him better, but not completely cured of the edema. So the secondary lymphedema is from radiation or injury or lymphangitis. You can read that quite quickly. It's usually related to a lot of radiation or tumors. So secondary lymphedema is a big problem, and we sell sleeves and leggings for both of that. This is a patient who has a malignancy. And the radiation therapy in treatment for certain conditions does cause damage to the lymphatics. And we know that resections cause women to have arms that swell because they've lost their lymph nodes and lymphatics in their axillary area. And these are changes that come in the leg from lymphatic congestion. And it's called phlebo lymphedema. And that's lichenification. The way it looks different than the hyperpigmentation from the venous disease. So you may see this in your clinic, sort of reddish, and it's bumpish. And on certain rocks, lichen grows, and they call it lichenification because it looks like when you're in the Nordic areas where they have lichen growing on rocks, it looks like that. And I just want to remind you that diuretics don't really help these people. It's actually the worst thing because they dehydrate them. And people with lymphedema need hydration, and they need wraps, and they can respond to massage. And in certain countries, they do more lymphatic surgery. In Brazil, they do quite a bit because they see more lymphedema related to elephantiasis. But in our country, there are very few specialists that work, and there are starting to be some more conferences about lymphedema, and there's certain centers for lymphedema. So you can look for that if you, in fact, have that. So the prevalence is really high. There are millions of people who have manifestations of lymphedema, and it's, they say it's close to 7 million people. But again, I think people cover it up. So there are these nice, flexi, touch, very expensive pumps that people really like, but they're almost $9,000. And the insurance companies have to have a lot of medical necessity to grant you the use of one, but people say they're really great and they work very well. So again, just reiterating the fact that when you see chronic leg edema or acute leg edema, you kind of have to put on your thinking cap and say, well, where's this coming from? What's wrong? It's either the valves aren't working or there's a blockage somewhere. And if there's a blockage somewhere, I really encourage you to find it. Don't just say, well, that's not my area. Send the patient to someone who knows how to find venous obstruction and treat it. Or at least don't just say, you got a normal scan in the ER and you can go home now. Because if their leg is swollen, there's a reason for it. So thank you very much for asking me to speak.
Thank you.